On behalf of the faculty, I'd like to give you a warm welcome to this first scientific session of this 12th St. Gallen Symposium. I'd like you to please enter the room and take a seat so that we can start. It's Swiss time, so it's just started, and we want to try to be on time so that we will be finished by lunchtime. Well, you all got the program at the entrance. There is a memory card on it with all the slides, so anybody who wants to focus more on the talk and not photograph everything, all the slides are in here for your convenience. You can take them home and then have a look at them. We would very much appreciate if you would fill out the evaluation form, which is in that abstract book, and if you maybe hand it over to the gentlemen and ladies at the side when you exit the room, that would really be appreciated. And the third housekeeping remark is you all got these pads. The pad is really big, so you cannot just put it in your pocket, and we would really appreciate if you would hand them as you turn out, hand them over again. And the faculty has really tried to make these talks as interactive as possible. So we have some case presentation. Please use the pads, and we will have this time for discussion after the presentations, so there's a lot of time for that. And if you have questions, please use the microphones which are in the rear. So this is the faculty, and I personally believe that we actually need no introduction really. On my right-hand side, starting off, is Dr. Kimberly Blackwell from Duke University in North Carolina, US. Dr. Blackwell is an expert in the field. She's very well recognized and known, so I don't think she needs a big introduction, and the same is true for Thomas Bachelot, a French colleague from Centre Léon Baron in Lyon, France, and he will give the third talk in this symposium. So the objectives of today is to discuss the clinical data that led to the current standards of endocrine therapy in the adjuvant setting in postmenopausal women with breast cancer. We would like to provide an update of the latest data on maintaining bone health in breast cancer and maybe beyond bone health. And we'd like to review the current options and limitations, emerging target therapies on mTOR inhibitors with and without endocrine treatment. You have the agenda in your program, and there's the usual disclosures with regard to symposiums like this. So with that said, I'd like to ask Kimberly Blackwell to set the stage for improving patients' outcome adjuvant therapy for breast cancer. Please.
Thank you. I want to thank the folks at Novartis and the St. Gallen Conference for allowing me to participate in today's meeting. Welcome to St. Gallen. It's always exciting to be the first speaker at such an important event, and I hope that you all spend the next 3 to 4 days enhancing your knowledge about the treatment of early-stage breast cancer. My task this morning is really to give you an update as to where we are with a broad overview of the use of endocrine therapy for the treatment of hormone-sensitive early-stage breast cancer. We're going to start just to wake everybody up here with a case. This is a case that almost everyone in the audience will have seen probably within the past 6 months if you're caring for breast cancer patients. And we'll start with a few audience response questions and answers. The first case is a young woman, 40 years of age, premenopausal, with a newly diagnosed early-stage breast cancer. No other illnesses, 3.5 centimeter tumor detected by mammography and also self-palpated. Moderate grade pathology, 95% of the cells staining positive for estrogen receptor in the US and throughout many parts of the world, an all-red of 8 to 9. 60% of the cells staining strongly positive for progesterone receptor, and HER2 non-overexpressing by immunohistochemistry. Stage 2A, and 4 positive axillary lymph nodes at the time of definitive axillary surgery. Staging studies show no metastatic disease, and our ECOG performance status is 0. She's scheduled to receive both adjuvant chemotherapy and then go on to receive adjuvant endocrine therapy. Let's assume for the purposes of today's discussion she received 6 cycles of TAC-based chemotherapy. So what do we know about the optimal role of endocrine therapy for young premenopausal women faced with high-risk node-positive breast cancer? Well, this overview analysis led by John Cusack and his colleagues was very insightful, at least in my practice, about a year and a half ago, because although there has been great controversy regarding the use of ovarian suppression in the setting of chemotherapy and or even in the absence of chemotherapy, this large meta-analysis, the largest done to date, has demonstrated that, in fact, that for women who, we'll start over, no, just joking. For women shown here on the right-hand side of the slide, that both in terms of disease recurrence and overall survival, for those women that are less than or equal to 40 years of age, there is a proportional reduction in disease recurrence of 25% in favor of the use of ovarian suppression, even in the setting of chemotherapy, and a 28% proportional improvement in overall survival for these very young women faced with breast cancer when they have ovarian suppression in this meta-analysis with the use of LHRH agonists employed as part of their adjuvant treatment regimen. Now, shown on the right-hand side of the slide are for premenopausal women over the age of 40 with the use of LHRH agonists. And although there is a small non-statistical benefit in terms of disease-free and overall survival, the largest impact of ovarian suppression in this meta-analysis really appears to be for the patient we're describing today, the largest benefit for ovarian suppression, those women in the youngest age group of women faced with breast cancer, less than or equal to 40 years of age. And it was around the same time that the Lancet article came out that a Cochrane analysis looked at the data, and in the context of stating that we should continue to support clinical trials that deal with the use of ovarian suppression in young women, the data from the currently published clinical trials of LHRH agonists in the adjuvant setting for premenopausal women with endocrine-sensitive breast cancer are supportive of clinical benefit. And I think that the strongest data to support this Cochrane conclusion statement really falls on the meta-analysis forest plots I just showed you, with this significant improvement in overall survival for the very young women faced with breast cancer. Now, how does this apply to the case we're describing today? Well, shown here in a horizontal bar graph, you see the annual rate of bone loss for premenopausal women who are treated with either ovarian suppression or have premature ovarian failure due to chemotherapy. And the comparison shown in the red box of either the use of a GnRH agonist or ovarian shutdown due to chemotherapy demonstrates a very similar annual rate of bone loss, close to 7.5%, independent of whether a woman receives chemotherapy and then goes into premature ovarian failure or is treated with a GnRH agonist. This is sevenfold the rate of annual bone loss in these young women as what is seen in a normal physiologic menopausal bone loss state. This really emphasizes that as we learn more about ovarian shutdown, suppression, whatever you want to refer to, where you take a young woman's ovaries and remove her high estrogen levels, there's a significant contribution to bone loss in these young women faced with early stage breast cancer. And this is really independent of the type of endocrine therapy that's employed. We'll get to aromatase inhibitor bone loss here in a second. So here's the first question. I promised that everyone needed to wake up. For this patient with high risk N2 estrogen receptor positive breast cancer, 40 years old, would you offer her ovarian suppression as part of her treatment plan, assuming that her menses resume after adjuvant chemotherapy? No, yes. Number 3, would discuss with the patient but not strongly recommend. And number 4, would recommend but would stop if menopausal symptoms become a problem. If you could please vote now. Okay. Well, either I convinced you within the first 5 minutes of the symposium or not, but at least in my practice, I would offer this young woman ovarian suppression based on the disease-free and overall survival benefits shown in the meta-analysis, even in the setting of chemotherapy. But I would also work very hard to manage her menopausal symptoms, thus having a limited impact on her quality of life. Next slide. If in fact you're in the majority and offer her ovarian suppression, how concerned are you about her bone health? 1, not concerned. 2, very concerned. Or 3, concerned, you have a high rate of kind of wanting to know what the ovarian suppression does to her bone, but would utilize regular monitoring strategies. Please vote now. Okay, so I would probably have voted with the majority here too, which is every medicine that we use, whether it be in oncology or general internal medicine, has side effects associated with it. And the known side effect of either lowering estrogen levels, whether that be through an ovarian suppression or removal of ovaries, its known side effect is accelerated bone loss. And so I think those who voted very concerned or concerned fall within my own thought process here. All right. So for those of you who are concerned about bone health, we have a number of now large completed phase 3 studies that look at how we can reduce or even remove this risk of accelerated bone loss. Most of you are familiar with this slide. It's been shown at many meetings and been published now for at least 2 years. In Lancet Oncology. And what you can see is that when you look at the bone loss associated in young premenopausal women not treated with chemotherapy but treated with an LHRH agonist, this study known as ABCSG12 led by Michael Nant and colleagues, you can see that when zoledronic acid, a bisphosphonate, in this case given twice a year, was not utilized, you see significant bone loss either with tamoxifen therapy, shown on the far right-hand side of the slide, or anastrozole therapy, showed on the second grouping of bars, to the point where at 3 years, 10% of women have had a significant change or loss in their bones. Compare this and contrast it to the right-hand side of the slide for women who received 3 years of ovarian suppression endocrine therapy alongside of zoledronic acid. Not only do you see complete obliteration of the bone loss, at least at the 5-year point, you actually see some gain in bone. This is a very different bone health picture in terms of DEXA monitoring for those women receiving 6 infusions of zoledronic acid over a 3-year period with no bone loss. Compare that to the women who have significant bone loss if they did not receive a bisphosphonate in the preventative setting. Let's go on to discuss postmenopausal women and optimal endocrine strategies. I'm going to spend the rest of my time really talking about a group of women who we know whose ovaries are postmenopausal or no longer producing high levels of estrogen, faced with early stage breast cancer. So case study number 2 is a 62-year-old postmenopausal female with newly diagnosed breast cancer, no comorbid illnesses, same tumor size as the last younger patient, 3.5 centimeters, self-palpated and detected by mammography, same markers, same strongly estrogen receptor positive, progesterone receptor positive, and let's say for the purposes of this case, 4 positive lymph nodes determined at, positive lymph nodes determined by clinical examination or ultrasound. Good performance status, given her tumor size and because of the multidisciplinary approach in facing her treatment plans, she's scheduled to receive neoadjuvant chemotherapy. She received 4 cycles of neoadjuvant anthracycline-based chemotherapy, and following her neoadjuvant chemotherapy, she has residual disease in the breast, less than 1 centimeter, and on the border of a micromet, but still 2 millimeter foci of invasive cancer in a single axillary lymph node. All of the rest of her lymph nodes are negative for residual disease. Here's the question. What is the next step in this patient's treatment? So let's say she's had her definitive anthracycline chemotherapy. 1, give her additional chemotherapy, followed by endocrine therapy. Number 2, initiate tamoxifen for 5 years. 3, initiate letrozole for 5 years. 4, initiate anastrozole for 5 years. 5, initiate exemestane for 5 years. Number 6, initiate tamoxifen and then plan to switch, let's say 2 to 3 years, to an aromatase inhibitor. Or number 7, any of the above plus an upfront bone-directed therapy. Please vote. All right, so a little bit more of a scattered choice, and I think number 1 is one that we're all grappling with as we use more neoadjuvant chemotherapy for larger stage tumors and use it as perhaps a predictive and prognostic marker. What is the role of additional chemotherapy, especially in hormone-positive breast cancer? And then there's a scattering across the board of aromatase inhibitors, with the minority of you utilizing either tamoxifen or exemestane. And then close to 1 out of 5 of you would utilize endocrine therapy plus a bisphosphonate or a bone-directed therapy. Next slide. So what are we worried about in this woman who has residual disease, postmenopausal, and residual disease after neoadjuvant chemotherapy? Well, this is another one of these slides that we've seen now for over 5 years, really addressing the idea of where are the moments of worry in a woman faced with early stage breast cancer, and where does breast cancer come back? As pointed out on the bottom of the slide, 3/4 of all breast cancer recurrences are distant recurrences occurring in visceral organs, liver, lung, brain, bone, with a smaller percentage of patients occurring in the local regional area, and then contralateral recurrences, almost certainly new primaries, occurring in the minority of patients. And it's really these distant metastases that lead to an impact on overall survival. And for those of us who are thinking about head-to-toe or systemic strategies to prevent disease recurrence, it is this type of recurrence that offers us a very definitive endpoint in determining whether our systemic therapies make an impact on the lives of women faced with early-stage breast cancer. So where are we as far as adjuvant endocrine treatment strategies? Well, shown here on one slide is really the 4 major approaches that we have utilized in thinking about how we can do better than our old friend tamoxifen. And these trials have looked at comparisons of upfront aromatase inhibitors to upfront tamoxifen in the case of Big 198, ATAC, and the TEAM study. We'll go over those studies briefly. There have been studies looking at, is it better to start one endocrine therapy followed by a different form of endocrine therapy, such as an aromatase inhibitor? And many studies have looked at this, including Big 198, ABCGS8, and TEAM. For the purposes of time this morning, we aren't going to be discussing switching strategies, which is really 2 to 3 years of tamoxifen followed by aromatase inhibitor, although that forms the backbone for many studies such as TEAM and Big 198. And then we will not be discussing endocrine extended adjuvant therapy such as MA17 or the recently completed NSABP-B42 or ABCSG6. But this is the idea of what do you do after 5 years of tamoxifen. So let's focus on really the patient that we're discussing here this morning, which is she's had her definitive chemotherapy. How do you go about making treatment decisions based on currently available large phase 3 studies? Well, here are the trifecta in the US horse racing lingo. of the large upfront tamoxifen versus aromatase inhibitor studies, Big 198, ATAC, and TEAM. And what's pretty amazing to me is we now have data on close to 60,000 women across the studies looking at the best approach for use of endocrine therapy in early-stage breast cancer. All three of these studies were large, enrolled both lymph node negative and lymph node positive patients, and all had, with the exception of ATAC, a prerequisite for estrogen receptor positive postmenopausal early-stage breast cancer. In addition, as you can see on the fourth line there, a good proportion, 40% in Big 198, 30% in ATAC, and 47% in TEAM, enrolled women faced with node-positive breast cancer. Across the board, close to 1/4 to 30% of the women had received adjuvant chemotherapy. So although there are some small differences, these three studies really represent similar patient populations faced with postmenopausal ER-positive breast cancer. And this is probably the one slide that I ask my fellows and my young physicians who I'm training to really understand and memorize. These are the primary endpoints for Big 198, ATAC, and TEAM. Different periods of follow-up. We now have 77 months of follow-up on Big 198. This is the early presentation with 26 months of follow-up. The last and final follow-up from ATAC occurs at 100 months of follow-up, and the results are shown in the middle column there. And TEAM, now with 60 months of follow-up, 5 years of follow-up, the results are shown in the yellow column there. What did we learn? Well, in terms of the primary endpoints of the study, both the use of letrozole and the use of anastrozole led to a significant improvement in disease-free survival, a 19% proportional reduction initially in Big 198, and a 15% proportional reduction now with the long follow-up of ATAC. We also saw a significant decrease in time to both recurrence and time to distant recurrence for the use of upfront anastrozole or letrozole. And although it would have been nice to have all three studies consistent with one another, the TEAM study was unable to document a benefit for the use of 5 years of exemestane versus 2 years of tamoxifen followed by 3 years of exemestane. And we'll go through each of these studies over the next minute or two. So here's a forest plot for those of you who visually like to look at forest plots in terms of the endpoints of these studies. This study is from ATAC, demonstrating both the 100-month follow-up, and as you can see in the purple box, the 68-month follow-up. It took over 100 months of follow-up in the ATAC to really see a reduction in time to distant recurrence, but the reduction or the improvement in disease-free survival and the improvement in time to recurrence has been consistent at all time points of the ATAC study. Here's another graphic representation of time to distant metastases from the ATAC study with the 100-month off-treatment period, or the 5-year off-treatment period demonstrated in the vertical dotted line. And what you can see is right around 3.5 years, there becomes a difference in time to distance recurrence in favor of the use of upfront anastrozole, shown in blue, compared to tamoxifen, shown in red. So what do we know about the use of letrozole? So ATAC was the first study to become available. Big 198 was the second study to become available. And although initially designed as a head-to-head comparison of tamoxifen versus letrozole for 5 years, it was amended in the late 1990s to add a sequencing strategy of either tamoxifen followed by letrozole or letrozole followed by tamoxifen. Now, for the next couple of slides, we'll focus on the letrozole for 5 years compared to tamoxifen for 5 years, arms A and B, totaling close to 5,000 postmenopausal ER-positive breast cancer patients. Now, similar to ATAC, there have been multiple points of analysis, and similar to ATAC, the endpoints analyzed at each of the analysis points shows a benefit for the use of an aromatase inhibitor compared to tamoxifen in terms of the primary endpoint of the study, disease-free survival. Here is the same Kaplan-Meier plot of distant metastases shown from Big 198. And although I'm afraid I didn't have a circle on the ATAC curve, you can see on this curve that the separations of the curve in Big 198 occur earlier than that of which we saw in ATAC. And in fact, so much so that there was a significant improvement in time to distant metastases that occurred at the very first analysis of the study, 26 months, such that there was a 27% proportional reduction in time to distant recurrence in favor of the use of letrozole compared to tamoxifen. Now, this is maybe important because I just showed you that the time period in which distant metastases occur actually occurs early on. Now, as a biologist, that makes sense to me. All of these adjuvant systemic therapies are trying to get rid of small micrometastatic disease that's undetectable by typical radiologic studies. And so this reduction in this early period of distant metastases probably will translate to an impact long-term in many treatment strategies, not just endocrine therapy, but also adjuvant HER2-based strategies. And so it's important to note that these curves in favor of letrozole over tamoxifen separate early in terms of time to distant metastases. Now, this study, the monotherapy arms, arm A and B, have been compared with 76 months of follow-up. And as most of you recognize, that when letrozole was found to be superior to tamoxifen, arm A, which was the 5 years of tamoxifen, was actually unblinded, and many of you participated in this study. And patients received a letter saying that we're unblinding arm A, you've been receiving tamoxifen, and if you would like to receive letrozole, it is your choice, not mandated, to receive letrozole. And in fact, 1/4 of the women in arm A switched from tamoxifen to letrozole. Because it was at a 26-month follow-up, most of the switching occurred after 26 months, between years 3 to 5. And the median duration of letrozole after the switch was about 18 months. Now, this creates a bit of a problem. The good news is that we figured out that letrozole was superior to tamoxifen. The bad news is that because women switched over, it allows for some statistical complexity in really understanding the effects of the crossover on the primary and secondary endpoints of Big 198, including disease-free survival and overall survival. Now, why does it create such a problem? Well, shown here on the right-hand side of this slide is the intent to treat analysis, which means that you analyze women who are randomized to tamoxifen as if they received 5 years of tamoxifen, knowing that 1/4 of them actually had a switching strategy. 1/4 of them got tamoxifen followed by letrozole, as shown with the yellow vertical triangle there. Now, this introduces a potential bias against letrozole because you're really comparing 5 years of letrozole to TAM followed by a proportion of women who received letrozole. Now, what about just taking those women out who switched over? That's called the censored analysis, and that was also presented by Dr. Moridson and colleagues. So in the gray vertical triangle, as shown by the arrow, the yellow arrow there, you can see that that's basically those women were removed from the analysis, and that's referred to as a censored analysis. Now, that introduces a potential bias against tamoxifen. So either way, there's an introduced bias, whether you leave the patients who switched over in, or you take them out in the form of the censored analysis. And so, as was published now 3-4 weeks ago in the Journal of Clinical Oncology, with a very complimentary editorial suggesting that we're going to have to use these types of analysis as we move forward, an inverse proportional censored weighted analysis, I think that's what it stands for, was performed. And what it basically does is for every woman who chose to switch over to letrozole from having initially been randomized to tamoxifen, for every woman who switches over, the woman who remains on tamoxifen is counted as more than one woman. And the women are matched based on certain prognostic variables, including performance status and number of positive lymph nodes. And this is a methodology that's been used across many other disease types, although as stated in the JCO editorial, this was the first time that an IPCW analysis had been published in the Journal of Clinical Oncology and spoke to the importance of the use of statistical modeling to really help us understand the accurate outcome of these studies where crossover occurs. So the IPCW was utilized with the weighting of the women who remained on tamoxifen and to hopefully balance out or reduce the bias for those women who chose to switch over. And here are all three analyses from Big 198. And just as you probably could have predicted, if an ITT introduces a bias against tamoxifen, and the censored analysis introduces a bias against letrozole, the IPCW, for all practical purposes, kind of ends up in the middle because it minimizes both of the extremes of the bias. And shown here in the purple boxes is the 17% proportional reduction in disease-free survival seen in the IPCW in favor of the use of upfront letrozole compared to tamoxifen. Overall survival becomes statistically significant at an 18% proportional improvement in overall survival, and that's very similar to the overall survival benefit for the use of upfront letrozole that was seen in the censored analysis and published in the New England Journal of Medicine. And then across the board, independent of the type of analysis, time to distant recurrence is improved for the use of upfront letrozole. Now, what about the sequencing strategy, just to finish up? And we'll see this also with the use of exemestane as well. Two pairwise comparison: is it better to use letrozole first and then switch to tamoxifen, shown on the bottom of the slide? Or is it better to use tamoxifen first and switch to letrozole as compared to 5 years of the same drug, letrozole? Median follow-up is 71 months, and the answer is it appears as though that the benefits of upfront letrozole really occur within the first 2-year periods, shown on the right-hand side of the slide. And this close over 4% absolute disease-free survival benefit appears to be the greatest in the woman we're describing this morning, that woman faced with node-positive breast cancer. When I describe these slides to my trainees, what I tell them is that it appears that extreme estrogen deprivation, that which occurs with the use of an AI compared to tamoxifen, really appears to make its major impact early on. And this becomes very apparent in women who are at highest risk of disease recurrence, those node-positive breast cancer patients. Now, I'm just going to finish up with the exemestane studies very quickly. As many of you know, MA27 will be represented by Dr. Goss later this afternoon. Very exciting presentation. And we've had 2 large phase 3 studies looking at the use of exemestane. This is the schematic for TEAM, initially presented at San Antonio by Dr. Jones a year and 3 months ago, and was recently published in The Lancet last week. So this compared tamoxifen followed by exemestane versus 5 years of exemestane, a type 1 irreversible inhibitor of aromatase in 9,779 women, the largest of the 3 phase 3 studies. And here are the results of this study. As you can see, there is no difference in disease-free survival for the use of upfront tamoxifen versus the use of upfront exemestane with 5 years of follow-up. And then MA27, which will be presented in, I assume, an updated form later this afternoon, looked at 5 years of exemestane versus 5 years of anastrozole. Very large study based in the NCIC, 7,500 women, 25 milligrams of exemestane versus standard dose anastrozole. And here are the hazard ratios, but for the sake of time, there was absolutely no difference between the use of 5 years of exemestane and 5 years of anastrozole. This is from the San Antonio presentation. I encourage you to go to the updated presentation later this afternoon. So in conclusion, the current evidence, including all of the international guidelines, suggests that the best strategy for treating postmenopausal ER-positive breast cancer patient is the use of an upfront aromatase inhibitor. We know in terms of the primary endpoints of these studies, which is disease-free survival, that anastrozole produced a better disease-free survival than tamoxifen, that's ATAC, that letrozole produced a better disease-free survival than tamoxifen, and there was an overall survival benefit when the crossover was accounted for in the Big 198 study. That's the closest we're going to get to an overall survival benefit in any of these studies. TEAM did not show a benefit for exemestane, and an MA27 exemestane was no different than anastrozole. It appears as though there are differences in the prevention of early distant recurrences between anastrozole and letrozole, with the differences between anastrozole and tamoxifen in distant metastases occurring later in the time frame, whereas in Big 198 we see a separation in distant metastasis rate early on. We're not going to spend a lot of time talking about safety profiles, but suffice it to say that both safety as well as compliance remain important issues and need further investigation in the treatment of early-stage breast cancer. So we'll finish up with this case. This is the patient with the T2 residual disease after receiving neoadjuvant chemo. I'll add 2 other components and then ask a question. You do a baseline DEXA scan, and she has a T-score of -1.6 in the L-spine and a -1.5 in the hip, and she has a family history of non-traumatic hip fracture. You've elected, based on the data we've just shown you, to initiate aromatase inhibitor. Does this patient need bone-directed therapy? De novo, right now. Number 1, no. Number 2, yes. 3, not sure. Or 4, I'm going to wait a year and see if she has additional bone loss. Please vote now. Okay, so all of you are interested in employing bone-directed therapy, but the question really is, when do you do it? Next slide, please. So we know that aromatase inhibitor therapy leads to accelerated bone loss, and the next speaker is going to do a very eloquent job of describing that. I just want to point out a couple of things. We have 4 large studies, including trials of IV bisphosphonates, oral bisphosphonates, and RANK ligand denosumab inhibitors, RANK ligand agonists. And as you can see, though, one of the important differentiating factors between all of these trials is that only one trial, or a group of trials, ZFAST, ZOFAST, and EZOFAST, really asks the question not whether you should use the bone-directed therapy, but when. And you'll hear more about this, but the ZFAST group of studies really looked at, should you employ it up front, or should you wait until you see bone loss? And we do not have that question with any of the other bone-directed, answer to that question with any of the other bone-directed therapies. This is a bar graph that really changed my practice as far as employing upfront bone-directed therapies for women who are being initiated on aromatase inhibitor therapy. And for the sake of time, I'll just draw your attention to the blue circles, suggesting that if you delay the initiation of zoledronic acid, close to 1 out of 5 women being initiated, in this case on letrozole, will derive osteoporosis within the first 12 months, 24 months, or 36 months. And so it's this study that really suggested, in my mind, to prevent the osteoporosis from developing, you need to employ an upfront bone-directed therapy. Very important slide for my day-to-day practice. So I'll just conclude and say that bisphosphonates help prevent bone loss, especially for those women either receiving ovarian suppression, as was in ABCSG12, or postmenopausal women receiving aromatase inhibitors such as ZFAST or ZOFAST, and that in conclusion, upfront aromatase inhibitor is the standard of care for the treatment of postmenopausal women with demonstrated improvement in disease-free survival benefits, as well as an overall survival benefit for the use of letrozole in Big 198. And with that, I think I'll turn it over to my chair as we move forward in thinking more about the effects of bisphosphonates on prevention of recurrence of breast cancer. Thank you very much.